Hello, my name is John Marshall, and I'm speaking to you from Toronto, Canada, as part of the Continuous International Sepsis Forum series, The Pocketbook of Sepsis. I'm going to be talking today about the multiple organ dysfunction syndrome, which in many ways is really the defining syndrome of critical illness, embodying all of the woes that our critically ill patients face. These are my disclosures for this talk, none of which pose any direct conflict with the information that I'm going to be presenting to you today. And as far as learning objectives, I'm not going to be speaking about the specifics of managing organ dysfunction, the fine-tuning the ventilator, or managing renal replacement therapy. Rather, what I want to do in the next 15 minutes or so is to provide a framework for thinking about the problem of organ dysfunction in the critically ill patient. I want to talk a little bit about the biologic underpinnings of organ dysfunction, but also to share with you the fact that much of this can be amplified iatrogenically by what we do in managing the patient. And then finally, I want to present to you a framework for measuring organ dysfunction and managing the syndrome. So let's go back approximately 2,000 years to the time of the Romans. Celsus was the first to describe the four cardinal manifestations of inflammation. He described these thinking about inflammation as a local process that produced redness, warmth, pain, and swelling. Approximately 100 years or so after that, Galen added to this loss of function or functiolesa. And these really have stood the test of time as the clinical manifestations of localized inflammation. I like to think of sepsis as being the systemic counterpart of this local inflammatory problem, where we're dealt with vasodilatation, temperature, altered consciousness, and increased capillary leak. And the local loss of function that occurs with localized inflammation has its counterpart in the multiple organ dysfunction syndrome. Indeed, when we redefined sepsis back in 2016, we emphasized the critical role that organ dysfunction plays in the process by defining sepsis as organ dysfunction caused by a dysregulated host response to infection. And I think one can really think about the process of organ dysfunction in the critically ill patient as being the interplay of three separate forces. One is the initial insult that caused the patient to become ill, whether it's a myocardial infarction, a pulmonary embolism, peritonitis, or multiple trauma. The second, and perhaps one of the most important, is the response of the host, the innate defense mechanisms that have evolved to allow us to withstand minor to moderate insults and not die. But finally, there's the response of the doctor. And that response includes both treating the insult and manipulating the response of the host. But it also can further cause insult and create kind of a vicious cycle of organ injury. And it's important in thinking about how to manage the patient with organ dysfunction to recognize that our interventions need to be mindful of all three of these separate insults to the patient. Now, organ dysfunction is very much a creation of contemporary critical care. This is a photograph taken during the time of the influenza pandemic back in 1918, 1919, at a time when there was really nothing that could be done for a patient who developed a life-threatening infection such as influenza, apart from cohorting them, keeping them comfortable, feeding them, perhaps giving them intravenous fluids. But if they developed bacterial infection, there were no antibiotics. If they developed respiratory dysfunction, there was no mechanical ventilation. And so the course of illness was either one of the body's response, saving the patient, or the patient succumbing to that underlying disease. And it's perhaps sobering to realize that some 40 to 50 million people lost their lives during that pandemic because we did not have the capacity that we currently have with the intensive care unit. This all changed in the early 1950s at the time of a polio epidemic in Copenhagen, Denmark. The Danish anesthetist Bjorn Ibsen came up with the idea that these children who were unable to breathe because of respiratory paralysis secondary to poliomyelitis might be kept alive if they had their breathing done exogenously. And so what he did is he arranged for these children to be tracheostomized and recruited a large number of medical students, residents, and other trainees to handbag them for 24 hours a day round the clock. And in doing so, there was some recovery of respiratory function, and the mortality of a disease that was 80% or more for children that had respiratory involvement with the polio virus dropped to about 15%. In the process, Ibsen created the specialty of critical care, a specialty which focuses not so much on treating diseases as on supporting the consequence that those diseases result in. In doing so, the intensive care unit has created an entire new spectrum of diseases. These are diseases that only arise in people who otherwise would have died from their primary insult. And so we see in the 1960s the first inklings of these new diseases being described as the acute respiratory distress syndrome in adults, the famous paper by Ashbaugh and Petty, or as septic shock, the manuscript by Lloyd McLean from Montreal, who described circulatory failure. And in the late 1960s, the first descriptions of what would come to be known as the multiple organ dysfunction syndrome. The recognition that in critically ill patients, often it was not a single system, but several systems that were failing. And the management of this combined process was really what challenged the intensivist. This was expressed very nicely by Arthur Bowie in an editorial he wrote in 1975, where he stated that the major factor after injury in patients who don't have brain injury is not so much a given system, but rather the combination of events. And he termed this multiple systems failure. So multiple systems failure, or multiple organ dysfunction syndrome, as we call it right now, is a complicated process because it involves multiple different aspects of biology and clinical management. It has characteristic physiologic features that include such things as an increase in vascular permeability that is disseminated throughout the body. It involves activation of innate immune defenses. And if we focus on the lung in particular, there's activation of alveolar macrophages, which results in local influx of neutrophils and in thrombosis in the microvasculature of the lung. But on top of this, there are also iatrogenic forces. Intubation and mechanical ventilation, which allows oxygenation of the blood and therefore keeps the patient from dying from acute hypoxemia. But a series of additional insults secondary to that iatrogenic intervention. We're bypassing the normal defenses of the upper airways and therefore subjecting the patient to an increased risk of ventilator-associated pneumonia. Fluid administration to counter changes in blood pressure in the setting of increased vascular permeability results in leakage of fluid into the lung interstitium and into the alveoli and worsens the oxygenation. Mechanical ventilation causes overdistension of the lung and shear forces on the lung, which cause further injury to an acutely inflamed organ. And finally, the process of managing the patient in the ICU, keeping them supine in bed, results in areas of atelectasis in dependent regions of the lung. You can see this very nicely on lung imaging. What appeared back in the 1960s to be a homogeneous disease process called the acute respiratory distress syndrome was revealed to be a much more complex process with the advent of CT scanning. Here on the right, you see the lung of a patient with the acute respiratory distress syndrome. And what's striking about this is the heterogeneity of the disease. Posterior regions of the lung are consolidated because secretions have pooled there because the patient is being nursed supine. And in contrast, the antidependent regions of the lung have developed air cysts because of overdistension of the lung. So ARDS is a physiologic process. It's a process associated with immune activation, but it's also a process associated with the doctor and the way we manage the lung and hypoxemia. Okay, so now if we think about the causes of the multiple organ dysfunction syndrome, there are a number of these, and they all conveniently begin with the letter I. Infection is a common cause, in other words, sepsis, but you can also get MODS secondary to direct injury to the lung. You can get it as a result of ischemia, either locally or distant, of sterile inflammation, such as in pancreatitis, of intoxications by a number of different agents, and there are iatrogenic causes of MODS as well. The cause is much less important in many ways because typically we have identified or managed the driving cause of MODS, and a lot of the continued evolution reflects either an incomplete management of the primary problem or the additional effects resulting from iatrogenic intervention. Now, the biology of sepsis and the multiple organ dysfunction syndrome is complex, and I don't want to go into this in too much detail, but rather to emphasize the number of processes that get activated. Clearly, there are pathogen factors that contribute to the severity of organ dysfunction, and activation of non-specific host defenses. Leukocyte activation with release of cytokines and a variety of bioactive molecules, oxides of nitrogen, for example, oxygen-free radicals, activation of the complement system, activation of coagulation with changes in coagulation in the microvasculature. And a lot of this leading to cell death, which in turn results in further host response and further activation of inflammation. But these processes are also associated with systemic disturbances in neuroendocrine regulation, in immune function, and even in gene transcription and metabolism, with essentially a shutdown of metabolic processes to support the acute inflammatory reaction. We know from a few unusual case studies that the syndrome of multiple organ dysfunction can result from exposure to a bacterial toxin. This is a case report of a laboratory worker who was depressed and tried to end his life by injecting himself with bacterial endotoxin. He developed a syndrome which we would all recognize as classical sepsis, nausea, vomiting, tachycardia, temperature, hypotension, that was responsive to intravenous fluids and dopamine. And he ended up ventilated and in renal failure in the intensive care unit, all secondary to the activation of the innate immune system by this bacterial toxin, endotoxin. This same process, though, can occur after other forms of immune system activation. We see organ dysfunction following CAR T cell therapy in hematology wards. It even follows injurious mechanical ventilation, as this very nice study by Marco Ranieri revealed. He showed that in patients in the ARMA trial led by ArdsNet, that those patients who were in the injurious ventilation strategy, the control arm, had increased release of circulating cytokines, whereas lung protective ventilation was associated with a reduction in cytokine release. Okay, so that's a very quick and admittedly inadequate overview of the pathophysiology of organ dysfunction. I want to focus a little bit on organ dysfunction's description, because we can really describe it in several different ways. We could quantify the physiologic abnormality. For example, we could measure the P to F ratio, we could measure the creatinine, we could measure the bilirubin as a measure of the function of a particular organ system that's involved. But equally, we can measure organ dysfunction as the intervention used to support abnormal physiology. We could talk about the use of mechanical ventilation. We could talk about the use of vasopressors or renal replacement therapy. And finally, we could convert all of these into a syndrome and describe it as the acute respiratory distress syndrome, as acute kidney injury, etc. Recognize that each of these gives us a particular perspective on a problem. They can also perhaps obscure some of the components of organ dysfunction. For example, if we talk about organ dysfunction as the requirement for vasopressors, we're not sure whether or not we're talking about a physiologic state or a disease where the decision of the doctor to administer vasopressors is actually making the syndrome worse. We, a number of years ago, developed a scoring system for organ dysfunction. There are a number of these out there now. This was one of the first of them. We looked at 6 different physiologic systems and scored abnormalities in them on a scale from 0, which was essentially normal function, to 4, which was markedly abnormal function, and a mortality risk of 50% or higher. And what we did is we used only physiologic variables here because we wanted to avoid the confounding of treatment with physiology. Now, this score is very similar to the SOFA score, which uses exactly the same variables. And even the selection of variables is, in a sense, somewhat arbitrary. What it reflects is not so much that these are the only systems that are impacted in critical illness, but these are the ones that we can measure, and these are the ones we can support. It's probably true to say that endocrine dysfunction, musculoskeletal dysfunction, cutaneous dysfunction, even dysfunction of the microbiome are all parts of the syndrome of multiple organ dysfunction. But the terminology we use does frame therapeutic decisions, and I think it's important to keep this in mind in looking after critically ill patients. When we talk about ARDS, we're thinking of a disease that perhaps has a biologic basis, and then we might be able to treat with some form of biologic therapy. If we frame this, however, as ventilator-induced lung injury, we focus attention on the importance of safe forms of mechanical ventilation to reduce organ injury. And it's striking that the advances that have been made in the management, or at least the attenuation of lung injury in critical illness, by and large have come from those interventions focused on reducing the risks of mechanical ventilation. A reduced tidal volume, prone positioning, perhaps the use of high-frequency oxygenation, the use of fluid restriction. And in contrast, we've been singularly unsuccessful in developing therapies whose primary focus is this very complex biology, which at this present time we really do not understand adequately to inform effective therapies. And so I'm just going to emphasize this point again. I think it's a general principle of organ dysfunction that every intervention that we subject a patient to carries a risk with it. Antibiotics disrupt the microbiome and set the patient up for superinfections. Sedation and analgesia bypasses airway defenses, increases the risk of delirium. Nutrition, certainly some kinds of nutrition can impact the liver function. Bed rest has its own impact on muscle function or on skin changes. And so what we really want to do is to support the patient as much as he or she needs it, but to try to minimize the damage that results from that support. So it's true to say that we really do not have effective therapies for multiple organ dysfunction syndrome. We have strategies to try to attenuate it that are generally focused on minimizing the harm associated with specific forms of organ support. And ventilatory support here is the best understood of these. The one possible exception to this is the role of a technique that was described 40 years ago, but it's not widely used, at least in North American and European ICUs. And that is the technique of selective digestive tract decontamination. It's a strategy that aims to preserve the gut microbiome by selectively suppressing overgrowth by aerobic gram-negative pathogens and fungi. And in this meta-analysis published just over a decade ago, you can see that in randomized trials of selective digestive tract decontamination, the use of the intervention attenuated organ dysfunction significantly. More recently, the Sudoku study that was reported by the Australian Clinical Trials Group showed a reduction in the risk of death associated with selective digestive tract decontamination. I show you this slide not to promote SDD, but rather to emphasize that multiple organ dysfunction syndrome is a process to be prevented rather than a disease to be treated. And our repertoire right now is very limited. So I want to just leave you then with this message that MODS is really the quintessential iatrogenic disorder. It only occurs in people who are alive because the opportunity to provide ICU level care has averted death. But once that has happened, everything that happens subsequently to that patient becomes a direct consequence of the interventions that were initiated, for better or for worse. And so we've realized that refining the care that we provide to critically ill patients is an essential component of minimizing the development of MODS, and therefore trying to maximize the outcomes for critically ill patients in the intensive care unit. A rapid and somewhat superficial overview of a very, very complex topic, but thank you for your attention today.